Hello everyone. I'm going to try and record a webinar to help you with the distinction grades that you can have a go at over the rest of the Easter holidays. This is my first time at producing a webinar, so I apologise if it's a little bit rubbish, but we'll give it a go anyway. As you can see, this is your Physiological Disorders assignment. And we're going to have a look at these things here, the distinction grades D1, D2. As you can see, it's not due until the 25th of April, but I know that several of you wanted to give it a go anyway before it was due in, so we'll give this a go and we'll see how we get on. We can always do a class on it when you come back anyway, so let's have a look at them. Get to them. Now it's worth mentioning that both the distinction grades do actually they link into this last task that you've all done. So you can see here that the M2 says discuss how the practitioners and the agencies involved in the care pathways work together to provide the care needed for both physiological disorders. So then you would have been talking about how the physiotherapist would work with the GP to try and come up with a care strategy just for that patient, this kind of thing. You've also will have planned a care pathway, which hopefully that you've included members of that team in your care pathway, and you've then for the P5 and the M3, you've been looking at the care strategies that can be used to support both individuals for both of the physiological disorders. So you've been looking at things like medication, surgery in some cases, complementary therapies perhaps, occupational therapies, physiotherapies, all of these things, all of the care strategies that are actually used for both of your case studies. So now we're going on to this one here, which is the distinction grades, and we'll get on to what they say in a minute, and I've got a little PowerPoint presentation to hopefully help us examine it a little bit closer. But the first thing you've got to note here is that both of the distinction grades ask you to write about one case study only. So for example, if you've written about asthma and multiple sclerosis, for instance, you only have to choose one of those. So you can discard one at this point, which I know they haven't done for the rest of the year, but you could discard one and write just about one of them. Choose wisely at this stage, and you can always email me if you're not sure which one you want to do, but certainly it's very likely that one of your case studies will lend itself better to the distinction grades than maybe the other one. For example, if you were doing asthma and multiple sclerosis, then in actual fact multiple sclerosis lends itself much better to being able to write the distinction grades. Not saying that asthma won't work as well, they all will work, but some of them have got more information and, shall we say, more controversy surrounding some of the care strategies. Okay, which gives you a little bit more to write about. Okay, so one case study only. Most of you want to know how many words to write, as usual. I always suggest maybe at least or the minimum of 1,000 words per distinction grade. Okay, see how you get on with that. You should be able to get 1,000 words out of both of these. There should be plenty to write about, and I'll try and put some stuff on Moodle for you to read and some resources so you can read up and research for both of these distinction grades to give you something to look at. Okay then, so we're going to look at the distinction grades. The first thing to note is that the command verbs at the beginning of each one of these distinction grades is the word evaluate. So you know then that you've got to look at the pros and cons or the strengths and weaknesses, and so make sure that you've evaluated. And it's always a good idea to read through your work before you hand it in. I do realise that this is quite difficult to do because you just want to get rid of it at this point, but it's always worth reading through it, and certainly when you go to the big school next year, it definitely is, so that you can almost tick it off to read it through and say, have I actually evaluated this this point? Okay then. So I'm going to go on now to look at a presentation. You can see here actually that a suggested source of information is the Health and Social Care books. I can't remember which one, but as you know, I've got several of these books available to me, so I'll try and find ones that are more appropriate for this D1 and D2 grade and see if I can't get you some information on it. Okay, I've certainly got another book here. It's called, it's actually a social care level 4 book, so it is a little bit advanced, but it just so happens it has a great chapter on multidisciplinary working in it, and so that will be quite good for this particular, the first one, the Distinction 1 grade. Okay, we're going to have a look now at a PowerPoint that I put together for these grades and see how we get on with that, and here it is. So you can see I'm being very good and using the Northern Regional College proper branded PowerPoint design. I thought we might as well. So here we go, let's get this thing going from beginning. There you go. So here we go, we're looking now at the distinction grades for physiological disorders. Sorry, I can hear something in the background now. It's perhaps going to be putting you off. And here we go. So this is a Distinction 1 grade. You've got to evaluate the effectiveness of health and social care practitioners and agencies working together to deliver the care pathway for one of the chosen physiological disorders. Okay, so basically what this is saying is evaluate the multidisciplinary team, or you could say it as evaluate the interprofessional team, or evaluate how the team working with your patients are collaborating. There's a lot of different ways of saying multidisciplinary team. Don't get these confused when you read up in the books. They all mean exactly the same thing. It's just a team of people that have come together to hopefully give the best possible care for your patient or the person that you wrote about in your case study. So, and it says here you've got to evaluate this, and as we go along in this presentation, you'll find out that occasionally things go a little bit awry and the multidisciplinary team don't communicate just as well together as maybe they should. And that's how you can suggest or evaluate the multidisciplinary team. You really are evaluating the benefits of working as a multidisciplinary team and the disadvantages or the barriers when you're working as part of a multidisciplinary team. And that's really what this distinction grade is asking you to do. You will find lots of stuff on the great research thing on the internet known as Google. Be careful when you're looking up and don't get too bogged down by some of it. If you Google the benefits or the barriers of working in a multidisciplinary team, you might get quite a lot of heavy duty journal articles come up. So be careful about that. So let's have a look at this. Oh, sorry, I'm going on to D2, just a wee summary of D2. The D2, the Distinction 2 grade, asks you to evaluate again the strengths and weaknesses of the care strategies that can be used to support an individual with one of the chosen physiological disorders. So what you've got to do then is look at all the care strategies that you wrote about for P5, and you've got to sort of say how good they are. So there might be a particular medication that somebody's taking, and the medication might be doing wonders for that person with that disorder. However, it might have some serious side effects. So you really, when people take medication like that, they really are looking at balancing whether or not they can cope with the side effects often in order to gain whatever benefit that medication might be giving. Okay, so there you go. I've obviously worked quite overtime to make sure that you could get the words out of this question. So I've highlighted here, evaluate the effectiveness, so whether or not all these people that work together are effective or not, to deliver the care pathway. And remember, this is a care pathway that you wrote about in P4 for only one of the chosen physiological disorders. So we're going to see what that actually means. So let's have a look. Hopefully this will work at a care pathway. This is actually mine, I suppose. And most of you will be very aware of this National Institute for Health and Care Excellence website, because I pointed you towards it when you were looking at your care pathways. And this is me here, an adult with type 2 diabetes. And the first thing to note on this care pathway is that if it comes straight down, the arrow comes straight down, it says individualized care. So the first thing you might consider is that one member of your multidisciplinary team is the patient themselves. Now, your Distinction 1 grade asks you to evaluate how the multidisciplinary team or interprofessional team work together, and quite often you will find that the patients themselves are left out of all kinds of case conference meetings, and in fact the information that the patient themselves get isn't particularly good. So that's one way you can evaluate how well the multidisciplinary team work together, by saying that maybe sometimes the patients themselves are actually left out. But in today's caring society, we really are looking at person-centered care, and also this is individualized care or personalized care. So the team has to really work together to provide that patient with personalized care that actually works for them themselves. And sometimes this doesn't go quite to plan because other members of the team, like GPs, insist that some tablets work, whereas perhaps for that person they're not working quite as well. Okay, so we're coming down here and you can see here that the patient, me in this case, should be getting patient education and lifestyle advice. This is usually carried out, in my case, by a diabetic specialist nurse. And so you've got to see how well that diabetic specialist nurse works together with everybody, myself included, to provide me with the best care. Now, I have a little bit of a confession here. I haven't actually seen my diabetic nurse specialist for a little bit of time. So in this case, the person themselves, the patient themselves, isn't really complying with the treatment. And I'm due to get a HbA1c test, and you'll all know if you've done diabetes that that's the blood test. And I haven't been for a while, so I really need to go and make an appointment. So this is the first stumbling block to working as part of a multidisciplinary team, is that maybe the patient themselves isn't very compliant, in my case. I put that to you that it's perhaps because I'm a nurse myself and therefore I'm fairly good at managing my own blood glucose, but I still really do need to go and see the diabetic nurse specialist. Now, you can see here that you've got come down here and it says managing lipids and cardiovascular risk. I take a statin for that. So that's a care strategy, if you like. But there's a lot of controversy around statins, and you will find a lot of stuff in the media about whether or not a statin, which lowers my blood cholesterol, and whether or not a statin is a particularly good thing to take. Some people would suggest it's a gold standard medication, that everybody should be taking it. You will find a lot of stuff on statins on the internet, and you can bring that into your Distinction 2 in this case. And this is how that the distinction 1 and distinction 2 really do interlink a wee bit. Don't worry, for those of you who like to write it all in one piece, I happily sort it out for you when I'm marking it, and I can work out which bit's the D1 and which bit's the D2, so don't mind it that way. On the other hand, if you're the type of student that likes to write the distinction 1 first and then the distinction 2, that's equally fine. I have no problem with that. Okay, I'm just going to quickly click onto this, because remember these National Institute for Health and Care Excellence pathways, all these blue banners down here, you can actually click onto them to find yet another part of the care pathway. We've got here managing blood glucose. That again is really linked in with my diabetic specialist nurse, but I do need a GP and a even a consultant to actually prescribe the medication that I need. So if you click onto this, you can see here I am again. You can see here HbA1c measurement, which is the bit that I've really got to go and get myself a blood test done. Self-monitoring of blood glucose. Again, guys, I can be a little bit rubbish at monitoring blood glucose. I know that you see me doing it quite often in college, and that's because I have to actually be very careful when I'm in college, because I typically end up running around like an idiot and talking to all you students instead of eating. So this is why I quite often do it in college. But when I'm at home and I'm eating better, I actually don't monitor myself quite as well as I should. So there you go. You can suggest maybe that could be a downfall again on my part, and the multidisciplinary team really does rely on me monitoring myself well. So I'm maybe not as compliant as I can be, although, and if you're writing this and you're writing about me, I think there might be one or two of you that are using me as a case study. Since I am a nurse and I kind of know that my blood glucose, it follows a certain pattern, and so therefore really I perhaps don't need to monitor it quite as well. Okay, so coming down here, we've got drug treatment here. This has to be prescribed by a doctor, so therefore the GP must work as part of the multidisciplinary team. And here, when you're talking about the D2 and the strategies, you can see here it could go either one or two ways. It says here initial drug treatment with metformin, which is my drug of choice at the moment. I'm on metformin 500 milligrams 4 times a day. I'm prescribed. I'll get to that in a minute. And however, you can see here that sometimes metformin is not tolerated very well by some diabetic patients. Metformin is the gold standard. Again, it's a gold standard treatment for, in this case, type 2 diabetes. But it's not tolerated by some people, so therefore they have to really go down another way. Coming back to myself, and you can see here metformin, it's a tablet that I take, it's 500 milligrams. It's prescribed to me 4 times a day, and that is quite a hefty dose of metformin. A lot of you will be aware that this time last year I had to go on insulin for a wee while, and eventually I was able to wean myself off of insulin. But instead I have to take quite a big dose of metformin to make sure my blood glucose is steady and make sure it's okay. But and here's another confession number 2. Even though I'm prescribed this metformin 4 times a day, I actually at the moment only take it 3 times a day. And again, so therefore we've got another little bit of a oopsie where as a patient I'm not really complying with the GP's treatment of me. There is again a reason for that, and that is because I guess I personalised my own treatment really, and I know that if I take 4 metformins then they build up in my system and I'm more likely to become hypoglycemic. So I think that 3 at this moment in time is plenty for me, and it seems to work. So ideally I'd go back to my GP and tell them that, but I'm a bit rubbish at if things are going well. I don't tend to go near the GPs, but there you go. As we come down here, it could say even a type 2 diabetic, if they don't manage their diabetes terribly well, they could end up in insulin-based treatments. Now, because I'm actually not really a type 2 diabetic, my diabetes is secondary to surgery. I do have a situation where occasionally I need to go on insulin, so I keep insulin around about the place, and you all know that. Okay, so that's me. So you can see how if you've done a very good care pathway, how you can almost follow the routes down, and you can see firstly how the multidisciplinary team work together, and secondly you can see some of the strategies. Only some of these niche ones tend to be a bit biomedical, so it talks about biomedicine treatment really, but you can have a look at those. So we'll go back to our PowerPoint slide. So there you go, and on and upwards. So we're going to look at interprofessional working, and this is what distinction 1 is asking you to do. And interprofessional working is yet another way of saying working as part of a multidisciplinary team, or working in collaboration with others to provide the best possible care. All of these terms tend to be exactly the same. So, and you can even see here on my, I've slipped into it here on my PowerPoint where I said integrated working, exactly the same thing. Just don't get a little bit too confused about that. It just means the same thing. And we're going to have a look, and I put here that some issues you might want to consider if you're right in the distinction grade, and it's evaluate how members of the multidisciplinary team or interprofessional working, the benefits of it and the barriers to it really. And I've put some issues you might want to consider: communication, control and choice, coordination of care, maybe confidence in care and carer engagement. I'm going to go through all of these, but you can see here you've got 5 of these, and even if you were to write 100 words on each one of those, remembering to write the benefits of good communication and the barriers to good communication, and you've got 50 words on each one of them and got 100 words out of it for communication alone, you've automatically got 500 words as part of your D1. So you might want to look at it like that. It's totally up to you. So we're going to have a look here at communication issues. Now, the first thing to consider is whether or not the patient is being listened to. Now, it was quite interesting seeing the my care pathway, because it was kind of the other way around, where I was kind of not complying with doctors at all. But quite often you will find that patients themselves are not listened to. They're not part of the multidisciplinary team. I have to say I've been a nurse for several years as well, you know, and I have had to be part of the case conference for many, many patients, and I can't remember a single time, much to my horror now, of course, I can't remember a single time that the patient themselves was actually invited along to the case conference. Occasionally I did see some, I think only once or twice I saw some of the loved ones to the patient invited along, but that's very rare. So here's a barrier to communication whereby the patient themselves might not be listened to. Now you can imagine, if you like, you've got a case conference in a hospital, we might as well use that, and the case conference has sitting around a nice round table, has got the staff nurse, myself maybe, who's coordinating it all as usual, might have the consultant, might have a physiotherapist, might have a social worker, might have an occupational therapist, might have a speech and language therapist, might have the ward manager, probably would have a registrar, quite often would have junior doctors along so that they can see what's what. So you've got all of these people sitting around a table discussing a patient. No patient there at all. But this is typically what it goes on like, and then we'll take out the medical notes of each patient and then we'll discuss the care going forward. and bit by bit each member of the multidisciplinary team will say something like, yes, I found that the physio's helping, but maybe if the nurses could get them up a little bit more, this kind of thing goes on. And so you can say that you've got a great benefit there, or that the fact that it's far better for the patient if all of those people come together and are talking around a table than if that didn't happen at all, because then everybody kind of gets to know what the other members of the multidisciplinary team do, and they kind of get to know what their role is in that patient's care. Very, very important. So that is quite a benefit of good communication, I suppose, in a multidisciplinary team. Now, one of the barriers to it, unfortunately, is that things rarely go to plan, shall we say, and it only takes one member of that multidisciplinary team to not be able to make that meeting, and this quite often happens because they've got other priorities, if you like, and then we've got one slice of the care, if you like, missing out on that meeting. Now, of course, you could minute meetings and send around minutes of meetings and say this was decided and that was decided, but it's kind of not the same if you're not there. So that can be a little bit of a barrier. Okay, you maybe, and this comes under whether or not it's easy to initiate communication with all of the different people involved in the care. Now, when you're looking at that and you're thinking about that, now I've just given you an example of a case conference in a hospital ward, but it's also missing perhaps the informal carers guys. And you can go to absolute town on this distinction one, talking about informal carers. In other words, all the people that are involved in the care of your patient that maybe aren't involved in a multidisciplinary team case conference. So it might be the parents of a child that you're talking about. It might be your mum and dad who's looking after an elderly relative. It might be the aunt that looks after the uncle. All of these people that actually are taking care of all your patients are rarely involved in the patients, you know, in the decision making regarding the care. And this can get quite difficult then, and this is what causes a lot of conflict, certainly in the hospitals anyway. It was usually the nurse's job to say, well, the parents of such and such feel that. But whether or not that was taken into account or not is another case entirely. So remember to look at informal carers and when you write your distinction one, because you'll get quite a lot of writing out of that. The next point says, does the patient feel informed? The easy answer to that, certainly in a hospital, is probably no. The unfortunate thing is that certainly in hospitals anyway, and most of your patients will have been in hospitals at one point or another, is that the consultant comes round and spends 5 minutes with you once a week maybe, and tells you a load of information that half of it you don't understand, and even as a nurse being a patient I perhaps didn't understand, and really you have to take some time to digest this information, and then of course then you've got all these questions that you would have liked to have asked the consultant, but unfortunately he's gone on to the next patient by then. So quite often and we as health and social care workers have to be very careful that the patient feels informed. Okay, and one of the ways that you can make the patient feel informed is whether or not there's some written supporting information. Now remember that not all communication issues are verbal issues. Documentation comes into communication issues too. And one of the barriers actually to working as part of a multidisciplinary team or an interprofessional team is the fact that typically, even at case conferences, doctors write in medical notes and physios write in their own notes, OTs write in their own notes, and nurses write in their own notes. This is called duplication, and it's a nonsense, and really all members of the multidisciplinary team would make far more sense if they were all writing in the same medical notes. Certainly they do in some hospitals in Northern Ireland, but the last time I knew in the trust, in Causeway Trust, they didn't, and this can cause a little bit of conflict. But it might be handy to have a good written supporting information for the patient themselves. This is often missing, and we as health and social care workers, as we go forward in our careers, should really think about providing that. Okay, onwards and upwards to the next issue, and this is control and choice. Now, I've already alluded to this, that the patient quite often doesn't feel that in control of their own care, and maybe a bit befuddled by all of the medical terminology that comes their way. And even if the patient is at home in their own house, sometimes they don't really have the choice of care agencies involved in their care. They can't just say, no, I don't want that district nurse come and do my dressings. That they really, just kind of have to put up with who comes and who's involved and be very thankful for it. Some of you I know are doing Alzheimer's or dementia, and this is quite interesting for you who are doing this, because many Alzheimer's patients and dementia patients are heavily involved, or rather the Alzheimer's Society are heavily involved in their care. They provide respite, they provide sort of buddies to go along and befriend, if you like, the dementia patients. They provide day outs, and they really are experts at what they do, the Alzheimer's Society. But when it comes to their patients then, and which often is the case, where a dementia patient has to go into hospital, the Alzheimer's Society are completely cut out then. They'd have no idea what's going on. And also the patients themselves, who really do trust the people that work for the Alzheimer's Society. I know this very well. Certainly here in Coleraine, I've worked with the Alzheimer's Society quite a lot in my time. And I am actually aghast, and I certainly know it does cause a lot of conflict for the people that work with the Alzheimer's Society, that they aren't allowed to go into the hospitals and give in their inputs to interprofessional working teams. So that's kind of a bit annoying. Also, patients might feel that some agencies are more effective than others. And this can go even in terms of, I'd prefer that physio rather than that physio, and such is the case. And what do you do then? There is quite a lot of conflict around interprofessional work, and you can look that up and give that a go. And also, at the end of the day, you might have this situation, and that is, what if a patient refuses care? What happens then? Now, I was talking about dementia patients and Alzheimer's patients there, and they will quite often refuse care. And then it becomes an ethical dilemma and what to do about that, because the patient themselves might not be fit to refuse their own care, and so the consultant could quite often employ the use of the Mental Capacity Act to declare that the patient isn't mentally able to refuse care, and go around that way. And then you can decide whether or not that is to the benefit of the patient or not. There usually is quite a lot of ethical dilemmas around care. Quite often, and you saw earlier that I wasn't very compliant with my care, and you do get patients that aren't compliant, and sometimes members of the multidisciplinary team are sort of knocking their heads against the wall going, why are we bothering even? Now, some of you might be looking at patients who are unfortunately, or will be unfortunately, terminal. That means that they are going to die from their condition eventually. Certainly if you're looking at cystic fibrosis maybe. And those patients are always under this cloud of the fact that they might not survive this disease. So they might get to the point where they refuse care and would rather have a quality of life over all of this treatment. So you're really weighing up the term quality of life against treatment options there, and this is very much within your distinction 2 criteria at this stage. You're looking at care strategies. Some of you might need to look at end of life care strategies as well. And this will give you quite a lot to talk about within your written work. Okay, so we're going to look at coordination of care, and care needs to be coordinated by someone. Often the coordination of the care is undertaken by the nurse specialist. I've talked already that case conferences are held, and we've already actually said that the patient often doesn't find out absolutely everything that is said in case conferences. I'm very nosy with my medical notes, and I like to read them, and for a certain extent I can understand what's been written in my medical notes, but it is very terminal. There's a lot of terminology there that most, say, people that weren't health and social care workers wouldn't understand, and quite frankly they're fairly scant, so it's not even worth it's not even worth reading them half of the time. You actually do need almost a one-to-one conversation with the specialist nurse to fully understand everything that's going on with your care. I have employed a strategy, certainly when I was working in the surgical ward, where I've got patients coming in for elective surgery. That means that surgery's been already pre-planned. And I've asked them to write down all of the questions they're thinking about before the consultant comes around, and given them a simple thing, a piece of paper and a pen. I said, just write, every time you think of a question, just write it down. And this has worked quite well, because you'll find, and I've done this as well myself when I was going to surgery, that you come out of a doctor's office and you forget everything that's been said, because you've got no written documentation to back it up. And then it's only when you're outside the office that you actually think of all the questions you'd like to ask. So ideally, you would have someone that could provide a bridge between what the system can offer and the actual care the patients needs. Now you will find that some patients, sorry I've got an itchy nose, some patients require what's called an advocate, and you can look up for your distinction grades the word advocacy. I'm pretty sure that in the last 2 years you will have come across this term before, of advocacy, probably in safeguarding or something, and you can think back and think about what you've actually written before about advocacy. But some patients actually need an advocate, and sometimes that advocate is one of their loved ones. Okay. Now then, we talk about confidence of care, and this is linked to control and choice, but centres around relationships. Now, ideally, for an interprofessional team to work very well together, they will have a very good relationship with each other, that everybody will know everybody else's roles and how they play out in the care of that one patient. This is very ideal, and it would be nice, but it kind of doesn't work like that, because sometimes nurses don't like the doctors, and nurses think that the physios aren't any good. Sometimes there's a situation where, and this is quite interesting at the minute, because of course this is a political moot point at the moment, where physios and OT certainly don't work weekends, and so there's always that gap in care. That drives nurses absolutely bonkers, that the patients are just sitting there in hospital wards. Nurses are there right enough to see to their care, but some of the other allied professionals are not working weekends, so maybe you can argue for 24/7 working. I can assure you that junior doctors are most certainly working every single weekend. So if there's a petition about trying to get Jeremy Hunt to lay off the junior doctors, I do suggest you sign it, maybe. But there you go, I've gone a little bit political there. Now you can think about in terms of control. Now unfortunately there is always a power relationship certainly between doctors and patients. Patients will tend to believe everything that a health and social care worker says to them, because they feel that the doctors themselves and the nurses have got all the knowledge and they have got no knowledge whatsoever. So they really are relying quite heavily on the doctors and nurses to actually be able to give them the right information. Now, in an ideal world, we would know everything and be able to do that, but sometimes this is not the case, and sometimes for some people, some care strategies aren't as good as others, and you'll be able to write about this in the distinction 2 bit. But you have to look at that relationship, and throughout the last 2 years, hopefully, you'll be looking at health and social care. And really, we need to be able to empower our patients, so you can look that up. And in a very good multidisciplinary team, you will be empowering the patients, okay? And then we're going to have a look at the timeliness of care, and quite frankly, patients when they're sick just want to get better ASAP, and this is just not this is kind of not able to happen a lot of the time, because the district nurse can't come round on the day that you want them, and you want them to be here right now and right then, but the district nurse has got other patients, and so therefore might be a bit late on it, and it's kind of this thing. And really, patients would like the fact that care services would respond and have some flexibility. Come and see them when they are in, for instance. Now, as health and social care workers, you do try to do that, but we've got other things to do and other patients to see, and unfortunately it kind of doesn't really work like that. Some of you might have patients that have been on waiting lists for some treatment, and it's just the way of the world. But patients, and what happens when this happens is that patients who are having to wait a long time tend to get very grouchy. They feel like they've lost control over the whole situation. They might get depressed, leading to yet more treatment being needed. So you kind of got to look at that timeliness of care, and kind of got to see how important it is to the patient, but how realistic it might be for members of the multidisciplinary team. And I've already mentioned this, care engagement. Our jobs, and I think this is the last point on this bit anyway, but our jobs are to empower the patient. You saw patient education, and you've all done a nice unit on promoted health education, I believe, in the first year. This is what it's all about: giving the patient choice, giving the patient some power back, allowing the patient to take risks sometimes. And we are there as health and social care workers to empower that patient, not to take any of those things away, or any of the dignity away. So you can talk a bit about that, and whether or not some of the treatment strategies or some of the ways that the multidisciplinary team working together actually might oppress the patients. It might be a little bit of patient oppression going around, shall we say, rather than empowering the patient. Okay, so another way of saying this is partnership working. Now I've got this, and it's a chapter of a book. Hopefully it'll come up. Sorry, I've told you a total lie. It's not a chapter of a book, it's a policy here, and it's living with long-term conditions, a policy framework. It's health and social care as public safety. Now if I click on this, it's a big thing. Look, it's got 60 pages. Don't worry about that. But if you see here, chapter 1 on page 14 is all about working in partnerships. See if I can get to page 14 for you. Might have to go this way. There we go. Bit slow on the old mouse. There you go. And you can see here, it's around the principle of person-centred care, really, and certainly you can write about that in your assignment, and it gives you some good information about people with long-term conditions and what is meant by partnership working. Partnership working is the same thing as saying working as part of a multidisciplinary team. So you can click on this, hopefully, and I'll provide this link on Moodle for you underneath, hopefully, this video, if I can get it up there. and you can click on that. Let's get us back to where we should be. Here we are. So there's something you can click on. And I've got some examples here, some YouTube examples. Now, rather than attempt to, because I can't get my head around playing a YouTube video in a video that I'm making, so rather than play these for you here and now, I'm pretty sure it probably would work, but this is my first go, so we'll see how it goes. I'm going to embed these videos, as I usually do, into Moodle. I'm literally going to do this as soon as I finish this video, so hopefully you'll be able to watch them. And these are just some examples of working as part of a multidisciplinary team. Okay, very quickly then, we'll look at evaluate the care strategies. And again, you're really looking at each one of the care strategies that you've prescribed for your patient, and they might be medication. And I think I did say, ideally, that you would include complementary therapy in one of your care strategies. Most of these conditions will have some complementary therapy that patients can try. Now, the reason I said that at the time was because of this distinction 2 grade. Because when we talk in terms of complementary strategies, complementary or alternative medicine, there is quite a lot of evaluation that can be done, because most complementary and alternative medicines have not been tested to the same gold standard that biomedical medicines and treatments have, and so therefore we can't say for absolute sure that acupuncture works for pain. However, your patient might rely on that acupuncture, and so therefore it's good for their well-being. And so this is part of complementary and alternative medicines, quite often part of something called psychosocial care strategies. For those of you doing nursing, you'll get to hear a lot about that when you go to nursing uni, because I think you probably do a whole module on it. So if you want to do some pre-reading, you can look up on it. There is lots of stuff, and I'll try and put some on Moodle about evaluating whether or not complementary and alternative medicine works. Okay. Remember, guys, you've got to look at the advantages and disadvantages of each of the care strategies, but only for one. Again, only for one of your chosen case studies. And you can go through the list that you've written and look up. There's always going to be some controversy surrounding most pills that people take, and you can look up each medicine and say whether or not the patient should be taking it or not, whether or not there's side effects, this kind of thing. And that's the end, guys. So I'll see if we can get this edited and put up on Moodle for you. See you later. Bye.